Well, welcome all, and thank you for joining us for our series called MST and Healing Conversations on Health, Relationships, and Care. Next slide, please. Today, we'll be focusing on the objective of summarizing issues faced when MST survivors struggle with co occurring substance use and eating disorders. Next slide, please. To obtain CEU credits, please make sure to follow the steps that I've shared in the chat and the steps you received via email. If you wish to receive a non-CEU certificate of completion, you can email me, and I've shared my email in the chat. So this would be for a peer support specialist or someone who isn't a psychologist or social worker, as those are the only CEUs we can currently offer. Next slide, please. And we'd like to extend a big thank you to the Wounded Warrior Project, a nonprofit organization dedicated to supporting post 9/11 veterans and service members through mental health services, rehabilitation, and community programming. We'd also like to give a big thank you to the Road Home program at Rush, which provides free evidence-based mental health care for veterans, service members, and their families, including weekly outpatient services as well as accelerated 1 and 2 week programs offered both virtually and in person. We're really grateful for their support to be able to make this whole series possible. And now we'll go ahead and get started, and I'll hand it off to my amazing colleagues, Dr. Leah Smith and Alana Shapiro.
Wonderful. Thanks, Mariana. Hello, everyone. Alana and I are really excited to talk today about two co-occurring disorders of particular interest. These are disorders that we often see pop up alongside experiences of MST as well as post-traumatic stress disorder or PTSD. We're going to be talking through kind of an overview of these co-occurring issues and also some clinical implications. At the end of our slides, we have some resources on different abbreviations that we're going to be using, our references. We also have some clinical recommendations for books and things like that. So we'll get to those, but I also just wanted to highlight that that's there in case you'd like to go to the course material early, just to kind of have those abbreviations on hand. We'll also be mentioning what they mean throughout our talk. There's just quite a few as we go through the eating disorder and substance use disorder world. So I wanted to highlight that. All right. So, and sorry, yes, you will be able to review the course information after the trainings. It should be, should still have access to that through that Google Doc or Google folder. And that's in the information that Mariana previously shared. All right, so I'm sure that many people have been to some of the previous presentations this month. We've been highlighting military sexual trauma this month in April, as April is Sexual Assault Awareness Month. But for those of you that maybe are just joining our talk today and weren't able to join some of the earlier talks this month, we wanted to include a little bit of information on military sexual trauma just to make sure that we're all on the same page at the beginning of this talk. So military sexual trauma, or MST, refers to any sexual activity that someone may be involved with against their will. MST may include instances of sexual assault or sexual harassment, maybe the combination of them, that are experienced during military service. MST is an experience that often or may lead to a mental health condition such as PTSD. The VA's national screening program has shown that about 1 in 3 women and about 1 in 50 men have reported to have experienced MST. Although rates of MST are higher among women, because there are so many more men in the military, there are significant numbers of both women and men who have experienced MST. And again, it's important to remember that MST is an experience, not a diagnosis or a mental health condition. And so, as with other forms of trauma, there are a variety of reactions that someone can have in response to MST. I do also want to include a note that while sexual trauma in non-military contexts is similarly detrimental to mental health, there are some unique features of sexual violence during military service that warrants consideration. In particular, survivors may live, work, and socialize alongside perpetrators. There may be support pathways that are institutionally linked. And such circumstances may contribute to things like institutional betrayal, where an individual feels kind of betrayed by their institution, feels like the institution betrayed some trust. So, other associated experiences include victim blaming, disengagement with military associated healthcare services due to distrust, and that sort of thing. So there was a recent review, it was actually published in 2025, that examined research investigating mental health outcomes associated with experiencing MST. So we wanted to highlight a few of these here at the beginning before we really dive into more of the details of eating disorders and substance use disorders. So first of all, the MST and co-occurring PTSD were obviously very prevalent, as we might expect. So the review found that compared to other types of trauma, MST was predictive of higher risk of developing PTSD and greater PTSD symptom severity. They found that military sexual assault is more predictive of probable PTSD and PTSD symptom severity than military sexual harassment. They also found that positive interpersonal support was shown to really help or buffer this relationship, while, as we might expect, intimate partner violence was exacerbating it or making that relationship between MST and PTSD worse. A couple other co-occurring diagnoses of note that they had in this review was MST and depression. So military sexual assault was more predictive of probable depression and greater depression severity than military sexual harassment, similar to PTSD in that case. But they did find in their review that religious service attendance was shown to help buffer that relationship. There was also some evidence of MST and co-occurring anxiety, showing that there were associations between those two, but there are also some demographic characteristics that impacted that relationship, so made it like more or less likely, depending on things like age, race, and gender identity. And then MST and suicidality. This review found that both military sexual assault and military sexual harassment increased the risk of suicidality, but that access to social support services helped to buffer that relationship. All right, and then finally, it brings us to the disorders that we're going to be focusing on more today. First being MST and disordered eating. Research in this review found that MST was linked with probable eating disorders and comorbid eating disorders among those with PTSD. And they found that psychological distress, especially increases in psychological distress, kind of increased the severity of that relationship. And then they also found some research examining MST and substance use or substance misuse, finding that military sexual assault consistently predicted probable substance use more so than military sexual harassment. So that's a little bit of a theme that this review found. And they also found that trauma exposure, so like amount of traumas that someone had been exposed to, PTSD, and depression symptoms impacted that relationship.
Thanks for that. And I think it's also helpful to talk about like why this matters and why we're talking about it. I think, with substance use disorders, eating disorders, and MST, like there's an interconnected public health concern here. So we know that suicide risk is higher for veterans with MST. Eating disorders are also the second highest mortality rate of any mental illness, secondary to opioid use disorder. 31 million Americans will have one in their life. And then we also know that PTSD and substance use disorders, again, frequently co-occur, have a more costly, complex, and difficult to treat clinical course. So I think this really speaks to the importance of screening and treatment because these things are life-threatening. And so sort of setting the stage of like why this matters and how important this is to talk about. Next slide, please. So now we'll sort of get more into disordered eating, eating disorders. I'm going to use the terms like more interchangeably throughout the presentation. Go to the next slide. Okay, so I think it is also helpful to define what an eating disorder is. These are the ones that the DSM has listed. We're really just going to focus on the first four because those are the ones that most occur with PTSD and MST. Anorexia has the highest mortality rate of any mental illness, the second highest, and then binge eating is the most common eating disorder. When we think of anorexia, it's defined by a restriction of energy intake leading to significantly low weight, a fear of weight gain, and their body is really sort of determining their entire worth. And there's a pretty low insight into the seriousness of it. Bulimia is binge eating. So that is a sense of loss of control, consuming an objectively large amount of food in a discrete period of time, eating more rapidly, and until uncomfortably full. Plus, there is purging to try and prevent weight gain. So that can be like laxative misuse, vomiting, diuretics, fasting, exercise as well. Binge eating is binge eating without purging. And there's often this like pretty intense distress afterwards, feeling of like guilt and shame. Other specified feeding or eating disorder is one where if you're not meeting the specific criteria for the other disorders, you may receive this diagnosis or you may give this diagnosis. So it can look like purging without binging. It can be restricting without low weight. And again, like this is not less serious. In some cases, it can actually be more. So all of these disorders are serious and do require treatment. Next slide, please. Okay, so when we talk about eating disorders in the military population, there are potentially higher rates of it seen within veterans. So one third of veteran women and 1/5 of veteran men endorse clinically significant eating pathology. And it's found that they have, two unique sort of risk factors that might create this perfect storm and really set the stage for disordered eating. One being increased risk of trauma exposure. So that is like during the military, it can be accidents, training, combat, MST. And also veterans and military personnel are more likely to have like developmental or childhood trauma and adverse childhood experiences, which is going to make them more vulnerable to eating disorders. Also, the military has a pretty strict focus on body composition. And so if somebody is not meeting those standards, they may resort to disordered eating in order to avoid repercussions from that. And so that in and of itself can really set the stage for disordered eating. And unfortunately, this does devalue health at every size and body diversity. And we know that there's a paradoxical reaction to restrictive eating, and our body does, receive that as a threat to survival. So there's a lot of physiological changes that can happen in the body that sets people up for overeating or binge eating and weight cycling, which we know has negative health outcomes. Also using like BMI and tape tests, which are more outdated tools for determining somebody's health status. All right, next slide.
Sorry, I was on mute there. So we want to take a moment here to touch base on the role of avoidance. And in particular, because this can be a really important factor for both of these comorbid disorders. So taking a step back, if we think about kind of after a traumatic event, such as military sexual trauma, people often experience symptoms that we see in PTSD, those intrusive symptoms, arousal and reactivity, negative thoughts and emotion. These reactions may trigger one another. So if you have an intrusive memory, it can lead to your thoughts or feelings kind of spiraling. You might notice some physical reactions as well. So for some people, these symptoms and reactions decrease over time, and they're able to experience some trauma recovery. We know from research that those who are able to experience that recovery are those that have the opportunity to think about the trauma, feel their emotions without avoiding. When people have the opportunity to process their thoughts, feelings, reactions, these strong emotions and physical responses decrease over time and eventually disconnect from one another. So the memory of the trauma doesn't provoke those like really strong reactions. People who go on to develop PTSD don't recover in the same way. Something disrupts this process of recovery, leaving the person stuck with symptoms long term. Not having a chance to process the experience may happen due to avoidance. In the beginning, avoidance may be unintentional or out of someone's control. Maybe this person doesn't have the opportunity to talk or kind of process what happened, to feel those emotions. They might be active duty when the MST occurs, for example. They don't really have a safe opportunity to go through kind of a helpful recovery process. So that might happen. However, if this continues and becomes the norm, avoidance might really kind of take over and prevent other symptoms from changing. So the key takeaway here of this slide, and I think the important thing to think about, is that avoidance, whatever form that takes, here we're going to be kind of talking about it as eating disorders, disordered eating and substance misuse, but that avoidance can stop this adjustment process or kind of stops this curve when it's kind of still going up. And until this traumatic event is processed and that avoidance is removed, it won't really go away and we won't really see recovery from the trauma.
Yeah, and I think going based off of that, we can see and conceptualize eating disorders within PTSD as a way to avoid distressing emotions, a way to soothe, distract, and escape these trauma symptoms. Also, there is a sense of like people might feel safer and more in control if they view their body as something that may have caused the trauma or a way to try and prevent future harm. Restricting or binging or purging can provide relief, numbing of these emotions, and provide a sense of control with food. And we know that it's not just a situational eating disorder or disordered eating from the military. We know that if you are engaging in these behaviors in the military, you are more likely to further develop eating pathology after the military. So the military can set this stage if you're predisposed to developing an eating disorder, especially when something like PTSD is in the mix. Eating disorders can be a way to try and initially cope with those distressing internal experiences. Also, I think it's important to note that usually or commonly people have like more than one traumatic experiences is not uncommon for us to see. And so the severity of the eating disorder is impacted by exposure to multiple types of trauma. We see PTSD at higher rates in higher levels of care for eating disorder treatment. Okay, next slide, please. All right, so this is more focused on like male combat veterans with MST. They were twice as likely to receive an eating disorder diagnosis. And just notably, like the research here is in the binary, talking about like cisgendered men, but we know that it absolutely happens outside of that. I think men with a history of MST have some unique challenges. There's toxic masculinity, so feeling like I should have fought back, I'm weak. Also, there's a questioning of their sexual identity that can happen. Um, and all of these disturbances can sort of lead to a different view of their body and themselves and their ability to protect themselves, and changing their body, and even with like an over focus on fitness, can be a way to try and prevent future harm, to feel more in control and to feel safe, and to also avoid distressing symptoms from PTSD if that develops. And we know that like it does provide this relief in the short term, but long term, these symptoms persist, and an eating disorder can sort of take on a life of its own and cause other issues as well. All right, next slide, please. So I'm curious if people want to put in the chat like what they have seen in practice is like what is the function of the eating disorder if you're noticing this in your PTSD patients from MST. I'm curious to hear others' perspectives. Based on the research, there is a connected symptom between eating disorders and PTSD when the body is used as self-blame for the cause of the trauma, and engaging in disordered eating is a way to find relief and control from that. Also with service members, like they may still be working alongside of their perpetrator, which can cause immense amount of distress. An eating disorder can be a way to cope with that. Trauma can also change self-esteem, causing like feelings of powerlessness. And so according to sort of this cycle here, when we overvalue our shape or weight in terms of sort of how we define our self-worth, that can be something that is maintaining the eating disorder cycle. And really all of these symptoms sort of play off of each other. And with restricting too, it can be the physical restriction, but it can also be like this cognitive restraint where people have food rules of what they can or can't eat. That can lead to binging, and that can lead to compensatory behaviors. And so all of this sort of reinforces each other. And something that can lead to that is this overvaluation of shape and weight, which can, and somebody's sort of perception of themselves can change from MST. And so part of this is, you know, figuring out what's maintaining it and other ways to cope effectively. But yeah, I will read off some things in the chat and see what people have said. Yeah, thanks for sharing that. It provides a sense of safety. If they eat to make themselves unattractive, it will prevent it from happening again. Exactly. Yeah, that's exactly what we've seen. Thanks for sharing that. All right, next slide, please. All right, so I think, one of the questions is like, what do we do about this? Because this can be really complex to treat when there's these co-occurring disorders. We know that there is a lack of routine screening. There can also be consequences to disclosing this if you are a service member. However, like we do need to screen in order to figure out like who needs treatment. And so the EDEQ is one that I would recommend. It has sort of a good stock of eating disorder symptoms and seeing like what's been going on recently. There is evidence that ACT or compassion focused therapy can be helpful, especially when sort of addressing this like negative self-talk and helping to decrease that when it's about their body, instilling hope, optimism, and personal strength is something that can mitigate sort of the relationship between PTSD and eating disturbances. Self-compassion can look like treating yourself with kindness, non-judgmental, and gentleness, because we know that these reactions make sense in the context. Also, we know that doing CPT or PE within the context of a higher level of care for an eating disorder treatment did see reductions of PTSD over time. About 70% of people did see these like symptom changes over time, which is, I think, really positive because we also often see this sort of like whack-a-mole phenomenon of you treat the eating disorder, the PTSD gets worse, and because of that, the eating disorder gets worse. So if we are able to treat it simultaneously and show that that is effective, I think that's really positive. CPT in particular does show holistic benefit for changing eating disorder and PTSD cognition simultaneously. And the research is really based on self-blame of like either my body caused the trauma or I'm going to change it to be unattractive to prevent future trauma by weight gain or weight loss. And so when somebody is able to sort of view what happened in a balanced way and no longer have that sense of blame, that can naturally shift some of these eating disorder thoughts and behaviors of, oh, I no longer need to do this because it wasn't my fault. And that was done at a residential eating disorder treatment. Yep, next slide. Thank you.
All right, so now we're going to dive into some information on MST, PTSD, and substance use disorders. Trauma exposure is a very common risk factor for substance use disorders or SUDs. In terms of prevalence, this is the general population about, not general per se, but PTSD population, not necessarily veterans. So overall, there's between kind of research has shown about 37 to 52% of PTSD populations will qualify for a lifetime substance use disorder. And then on the other hand, about 26 to 56% of substance use populations will qualify for a lifetime PTSD. So there's a lot of overlap between the two. And research has shown that when PTSD and substance use disorders present alongside each other, this comorbidity is often complex, very difficult to treat, and marked by a much more kind of chronic clinical course. Among veterans, a history of MST has also been associated with greater risk for substance use disorders among female veterans in particular, and alcohol use disorders among male veterans. More research is needed to kind of really explore that more, but that's what the current research has kind of good evidence for. So I want to highlight some functional impairments of this comorbidity. And some of these functional impairments are also ones that we might kind of first see pop up in some clinical settings, kind of across clinical settings, both medical and mental health. So the first one that I want to highlight is physical health and physical injuries. One in particular that is salient here is physical injury and pain. PTSD itself may result from traumatic events that include some element of a physical attack. And so physical injuries following these types of traumatic events can lead to a broad range of health issues, including chronic pain, also traumatic brain injuries in some cases. Similarly, substance use disorders are associated with increased risk for injury. And in this way, each disorder has strong associations with physical injury, although sometimes for different reasons. Injury and pain may also render some individuals with PTSD and substance use disorders as less able to engage in physical activities, such as regular exercise. These injuries or pain may impair sleep, and overall, this could kind of further compromise their health. Some other health behaviors. Research suggests that individuals with PTSD and substance use disorders are more likely to be physically inactive. They might kind of restrict where they're venturing out, for example. They are also shown to have poor sleep and engage in unhealthy eating habits, including binge eating and eating fewer healthy foods. So these poor health behaviors may influence physical health by increasing inflammation. They also increase the likelihood of vitamin deficiencies and also increase oxidative stress for the individual. There's also some mental health symptoms where we might see functional impairments popping up. First, I want to talk about internalizing symptoms. So overall, individuals with PTSD and substance use disorders report a greater number of internalizing symptoms than individuals with either condition alone. For example, in addition to more severe symptom presentations, individuals with PTSD and substance use disorders also face higher rates of comorbid mental health conditions like depression and anxiety. These individuals might also report more maladaptive cognitions, like kind of things related to self-blame, rationalization of substance use, than individuals with PTSD alone. And research has illustrated that those with PTSD and substance use disorders may experience greater internal stress and more severe overall impairment, which may kind of ultimately manifest in a greater number of negative cognitions. I'd also like to talk about externalizing symptoms. So among individuals with PTSD and substance use, externalizing behaviors such as aggression and violent behavior have also been shown to be more prevalent. For example, there was a study by Barrett and colleagues in 2011 finding that 54.7% of individuals with PTSD and substance use had engaged in violent behavior in their lifetime. These authors also showed that higher rates of substance use and greater PTSD symptom severity were associated with higher rates of violence perpetration. Other data has also shown that individuals with PTSD and substance use disorders have more trouble or may have more trouble controlling their violent behavior compared to individuals with substance use disorders alone, or those with substance use disorders and another comorbid condition like depression. Close relationships may also be impacted. Individuals with PTSD and substance use disorders have shown lower relationship satisfaction, more marital distress, and also more conflict. Among those who are parents, these disorders have been linked to less effective parenting, less parental satisfaction, and greater parental distress. Research has also shown that individuals with comorbid PTSD and substance use disorders may experience more interpersonal problems and less social support than those with either of those disorders alone. Finally, I'd like to take a peek at cognitive functioning. A 2012 review found that PTSD was associated with problems in inhibiting automatic responses and also regulating attention. Similarly, chronic alcohol or drug use has shown effects on cognitive abilities, such that heavy users show both short and long-term cognitive impairment. In conjunction with this, certain symptoms related to these disorders, like sleep disturbance, may themselves lead to worse neuropsychological performance, such as lower processing speed, worse executive control of attention, worse visual memory. And these cognitive deficits may impede an individual's ability to solve complex problems or complete important tasks, either at work or within social relationships. All right, so I want to touch briefly on some models as to why these co-occur. So why we might be seeing MST, PTSD, and substance use disorders. The first one that I want to touch base on is our shared liability model. This suggests that PTSD and substance use disorders frequently co-occur due to common familial risk, such as genetic factors and also environmental influences. The strongest support for this model is derived from twin studies. These estimate the proportion of variance within a population that can be attributed to genetic factors, shared environmental influences, and non-shared influences. A number of twin studies have documented significant genetic and shared environmental influences on trauma and substance use. For example, familial risk explains a significant amount of variance in interpersonal stressful events and traumatic event exposure. In other words, the tendency to experience interpersonal stressors, including interpersonal traumatic events, may run in families, in part possibly due to genetic factors. Substance use disorders have also been found to largely be determined by genetic factors. Although there are common genetic risks underlying multiple types of substance use disorders, a significant portion of genetic risk for substance use and substance use disorder appears to be substance specific. So in other words, one individual could have elevated genetic risk for an alcohol use disorder, whereas another one could have an elevated risk for cannabis use disorder. Alongside this genetic and environmental risk, I'd also like to mention the potential influence of the HPA axis. So the HPA axis is a part of our body's stress response system. Its dysregulation has been associated with many negative health outcomes. In fact, dysfunction in the system has been linked to some of the same health problems associated with PTSD and substance use disorders, in particular cardiovascular, metabolic, and gastrointestinal disorders. So it may be a mechanism that helps explain what contributes to kind of the connection of these and also to other medical conditions. So how does this happen from the HPA axis? Well, for one, there may be an increased release of pituitary and adrenal hormones, including cortisol, that kind of big stress hormone, which then compromises the body's immune system. Also, disruptions in the HPA axis appear to increase levels of pro-inflammatory cytokines, which increase inflammation throughout the body. And then finally, activation of these stress response systems may increase oxidative stress, which is a chemical process related to the aging of our cells. Oxidative stress has had a lot of more research recently, and it's shown links between diseases like diabetes, heart disease, and also neurocognitive disorders. I also want to touch base on the self-medication model. This one is pretty common, pretty widely known. This presumes that individuals with a history of trauma or PTSD are at increased risk for substance use disorders due to repeated use of substances to cope with trauma-related symptoms. This hypothesis is largely rooted in operant conditioning theory, in that individuals who use alcohol or other substances to cope with trauma-related negative affect may experience some temporary relief, which in turn negatively reinforces the use of substance in kind of other difficult emotional or situational contexts. We can also think of this from a classical conditioning perspective, in that as trauma reminders and related symptoms become paired with substance use, these reminders and symptoms become a conditioned stimulus for substance craving. So this theoretical model is pretty intuitive. In fact, a lot of clients with comorbid PTSD and SUDs often endorse using substances to cope with negative affect, and they also report that they perceive there to be these like functional links between PTSD and substances. The final model is this susceptibility model, which this presumes that substance use and substance use disorders increase risk for trauma exposure and or PTSD. For example, a Kotler and colleagues study found that cocaine and or opioid users were more than 3 times as likely compared to non-using controls to report 1 or more lifetime traumatic events. And they were also significantly more likely to meet criteria for a PTSD diagnosis. They also found that these substance use preceded this age of onset for PTSD. So that study provided a lot of evidence in support of this susceptibility model. No matter which model you think kind of makes the most sense for your particular client, there are also some transdiagnostic factors that show up and really contribute to the comorbidity of PTSD and substance use disorders. Distress tolerance, particularly low distress tolerance, is one of those. Distress tolerance is this perceived or actual inability to tolerate negative emotional experiences. So individuals with low distress tolerance might find some symptoms of PTSD particularly distressing because of the intrusive and unpredictable nature of these symptoms. Among those with substance use disorders, we would expect feelings like of distress to motivate substance use and to be associated with returning to substances more rapidly after failed quit attempts in order to kind of escape or avoid from the discomfort of withdrawal. The second transdiagnostic factor that I want to highlight is anxiety sensitivity. This is a fear of anxiety or arousal-related symptoms. Anxiety sensitivity may predispose some individuals to kind of catastrophically interpret symptoms of PTSD or substance use withdrawal, which may lead to kind of avoidance and negative coping behaviors. We also have emotion regulation. This is a difficulty in awareness and understanding of emotions, difficulty accepting emotions, difficulty controlling impulsive behaviors, and difficulty kind of using situationally appropriate emotion regulation strategies. Studies overall have found that both PTSD and substance use disorder are associated with greater difficulties in emotion regulation. And overall deficits in emotion regulation may not only connect PTSD and substance use disorders to one another, but may be a shared variable that connects these two disorders to other harmful mental health conditions. And then finally, coping style. This is an individual difference variable that has long been linked to PTSD and substance use disorders. Maladaptive coping in particular may at least partially explain the co-occurrence of these two disorders and may also be a factor leading to harmful mental health outcomes associated with this comorbidity. The use of maladaptive coping strategies often results in kind of paradoxically this greater rather than diminished levels of distress, and individuals with PTSD and substance use disorders may experience worse mental health outcomes as a result of engaging in more frequent maladaptive coping behaviors. All right, so at this point, I just want to kind of take us out, kind of bring in this perspective for a second where we're just remembering this kind of harmful cycle that can crop up for individuals with PTSD and substance use disorders. Oftentimes we might have our traumatic experience leading to effects of trauma, mental health symptoms, leading to someone kind of motivated to self-medicate, right, to avoid or escape those symptoms. And then that same substance use can lead to further changes in neurochemistry, worsening those mental health symptoms even further. Adding to this complex relationship, withdrawal from substances may closely mimic some symptoms of PTSD, for example, sleep disturbance, difficulty concentrating, or feelings of detachment and irritability. And that can contribute to kind of further reinforcing the cycle of self-medication that some individuals really struggle with. So clinically, it can be really helpful to kind of go over this cycle with patients and figure out where there might be some kind of intervention opportunities. And that leads us to treatment approaches. So until recently, the most common treatment model employed across settings was the sequential model of care, which posits that substance use disorders need to be treated first, and trauma-focused interventions should be deferred until there's sustained abstinence from the substance use. In the sequential model, interventions for substance use disorders and PTSD are typically provided by different clinicians, usually across separate treatment clinics. And despite little empirical support, this sequential model continues to be maintained in practice for a few different factors. First, some clinicians are concerned that continued substance use during PTSD treatment may interfere with the cognitive or emotional processing of trauma. Second, some may be concerned that engaging in PTSD treatment will serve to maintain or increase ongoing substance use. And third, clinical providers are often trained, this is more of a practical note, but they're often trained either in the assessment and treatment of PTSD or substance use disorders, but rarely both. So in this case, there's preference for the sequential model because of, again, these pragmatic issues such as insufficient training or limited familiarity with the comorbid condition. That said, there's been a lot of research recently that has advocated for a concurrent or integrated model of care. And this has really emerged as a result of the challenges kind of inherent in the sequential model, including high relapse rates, limited care coordination between providers. Concurrent models of care generally offer treatment for PTSD and substance use disorders at the same time, although it still may be by different clinicians. For example, a client may be in individual PTSD treatment with one provider and SUD treatment with another at the same time. As another example, individuals in residential treatment for substance use disorders may be offered weekly PTSD treatment in the form of individual or group therapy. Integrated models of care underscore the importance of the intersection of PTSD and substance use disorders, and thus indicate the treatment of both disorders simultaneously. This model of care is largely informed by the self-medication theory that we touched base on earlier, which again purports that substance use is driven in part by an attempt to medicate the symptoms of PTSD. According to this integrated model of care, providing psychoeducation regarding the interplay of PTSD and substance use disorders and targeting PTSD symptoms alongside substance use disorder symptoms may improve our long-term outcomes. A couple evidence-based treatments that offer integrated models of care include the ones listed here. Just briefly, the first one is seeking safety. This is a present-focused cognitive behavioral psychotherapy specifically designed to address both trauma and post-traumatic stress and substance use disorders using an integrated approach. It focuses on the recognized need to establish safety in the process of recovering from the negative impact of both trauma and addiction. This connection between trauma and substance use is introduced early in treatment, and both issues are addressed simultaneously throughout each model. The next one that I want to highlight is COPE, or the concurrent treatment of PTSD and SUD using prolonged exposure. This is a 12-session individual cognitive behavioral therapy that integrates a full course of PE for PTSD with CBT for SUD. So to date, COPE is the only integrated treatment for PTSD and SUD that includes a full course of PE. COPE is designed to be used to treat PTSD resulting from various types of trauma while simultaneously targeting alcohol and drug use disorders. We also have ICBT, the Integrated Cognitive Behavioral Therapy approach. This is a time-limited manualized intervention that can be delivered in group or in an individual format. It's designed to be easily implemented by clinicians working in community-based settings. It's based on the principles of cognitive restructuring. It targets PTSD symptoms, substance use, and their interaction through 3 core components. Those core components are 1, cognitive restructuring, 2, centered and breathing retraining or kind of mindful relaxation, and then 3, client education about PTSD and substance use symptoms. Finally, there are some third-wave behavioral therapies, including things like ACT and DBT and various mindfulness-based interventions that have shown some promise in treating this concurrent PTSD and substance use. And while they've shown some promise, more research is really needed to kind of provide empirical support for treating these both simultaneously. But I know that there's currently a lot of research underway that is seeking to provide that. So we might kind of see these third wave therapies pop up even more in the coming years. And then the final point that I wanted to mention for the section on substance use disorders is CPT, or cognitive processing therapy, for PTSD and SUD patients. Cognitive processing therapy is the primary treatment that we use at the Road Home program. It's found to be effective in veterans with PTSD and SUD, so that co-occurring condition. There's also been studies comparing it between outpatient and residential treatment settings, showing that both are effective. In kind of the practical application of this, CBT worksheets, if you're familiar with CBT, there's a lot of worksheets. And these worksheets help to engage the kind of thinking side of the brain rather than the emotional side of the brain, which help a patient to kind of slow down, think through the cognitions that are coming up, and kind of use an alternative coping strategy rather than substance use. Some stuck points that might come up for someone that has a comorbid substance use disorder while engaging in CBT are things like, I have no control over what I do when I have an urge to drink. Maybe a thought along the lines of, I won't be able to deal with my symptoms unless I'm using or unless I'm drinking. Or I deserve to be raped because I'm an addict. So CPT would be able to really effectively target those example stuck points and many others that a patient with this comorbid PTSD and SUD might present with.
All right, so these are just some resources we wanted to include. I won't go over in too much detail, just in interest of time, but there is PTSD and substance use disorders, more of a comprehensive clinical handbook for like researchers and clinicians. The trauma-informed workbook for addiction offers evidence-based tools in DBT and CBT. This is more for clinicians and clients. Getting Unstuck from PTSD uses CPT to guide recovery, which is a really good resource for clients in CPT treatment. Health at Every Size introduces weight as like a neutral approach to treatment, acceptance-based approach to eating disorder treatment, and understanding body diversity, and that like pursuing weight loss or diets can actually like negatively impact health in the long term. So it gets more into detail about that. and cognitive behavioral therapy for eating disorders, or CBTE, is a clinician textbook, which is like an evidence-based treatment for eating disorders. All right.
With that, thank you all for your attention during this presentation. We're happy to take any questions, and thank you all for joining us today. I also wanted to highlight for those that are able to download the materials, there's some information on different abbreviations we used and different references as well. One person in the chat asked if there are studies linking MST to erectile dysfunction. That's a really good question. I would imagine, I don't know specifically. I would imagine that there may be some studies looking at that. I think if something I'd think of kind of off the top of my head is that a treatment like cognitive processing therapy or CPT would be able to help address maybe some maladaptive cognitions related to kind of performance and that sort of thing. So that would be a treatment I might kind of initially lean towards for someone experiencing that.
And I wonder too with that if like, it's normal to sort of like question your sexual identity after an MST and if that's playing into it. And so using again like Socratic questioning with CPT, like I think that can be helpful.
Scrolling through for any other questions.
There's some good questions here in the chat. With I'll just ARFID first. I think with ARFID, so that is like a little bit more, I think, complex because there's a lot of factors that can contribute to that. There's like low interest and reward with eating, sensory sensitivities, and then also like fear of aversive consequences like vomiting or choking. So that leads to food avoidance. But there is not any distress like around body image and weight. So that would be like one of the primary differences. I hope that is helpful. But let me know if you have any further questions. Coordinating care, yeah, I think that can be really challenging and also like really important for eating disorder treatment. There is like the medical management of the illness, which can be like from a doctor, and then also like a nutritionist can help with like regular eating and incorporating these more off limit foods. And yeah, I think having that team can be really helpful. I don't know if you can speak to like the addiction specialist part of it.
Yeah, I mean, any place where there's available integrated treatment is really uh, just such a valuable resource. There are, I know, more options these days for linking medical charts and that sort of thing, even outside of the VA. So I think that really helps with coordinated care, but it's still really coordinating that care well is still really on, I think, the lion's share of responsibility of that is on the patient or loved ones that are caring for someone, unfortunately. Um, that is, however, one thing that we really try to emphasize at the Road Home program while people are here doing treatment is being able to provide a space where we're able to coordinate their care kind of more effectively um, and really promptly and helps kind of set them up to do the same thing in their home setting. But it can be really challenging.
Mhm.
I also wanted to speak to quite a few, or a few comments have mentioned MST and erectile dysfunction or ED. Um, I'm not as familiar with that, but I wonder if that might be a good topic for this series in coming years, honestly, um, because I think it's an important one. Um, and yeah, I think in terms of like today's talk, sometimes with substance use, we also see some ED come up. Um, but in most of the treatments that I talked about, the focus is really on trauma and substance use. And then something like ED would be kind of like if that was continued following the like integrated PTSD and substance use treatment, it would be kind of addressed as a related concern, but like following that, like those primary treatments targeting PTSD and substance use. And hopefully those treatments would address some of what's going on with ED, you know, maybe this like kind of psychological components of it. Those treatments would obviously not be able to address any medical components with that, aside from any aspect where the substance use is causing some of that ED. You know, I'm thinking of like kind of alcohol use disorder in particular and how that might have a connection. So yeah, I am only really able to speak to that in kind of related ways, not directly. Alana, I don't know if you have any insights into that, but I think it'd be great to see a talk on this in the future.
I agree. Yeah, I think again, like that can be pretty multifactorial and some of the causes of that. Also, like I'm wondering if, sometimes medications that are prescribed like for PTSD can impact that as well. But I agree, it's a really good question. And I don't know. Yeah.
Absolutely.
Yeah.
Yeah, it's a really good point about the medication.
Mhm.
Yeah, and I like the idea of including kind of the equivalent issue for women.
Mhm.
Absolutely. We do have a lot of resources for pelvic health um, within the Road Home program. And I know there was a talk on that earlier, but even with that, a lot of it is kind of focused on getting back to functioning, like kind of like bare minimum functioning. And I think being able to uh, think about or kind of address issues surrounding pleasure or enjoyment, that's a whole other level.
Mhm.
That is really, really important for functioning and for people's relationships. But sometimes, a lot of times, we're not able to even like get to that point because we're just working on, um, if people are lucky, they're able to work on those like functional aspects of their pelvic floor, let alone the like pleasure aspects of it, unfortunately. But it's certainly a really important area for a lot of patients.
Any other questions?
Great questions and comments. Thank you, everyone.
All right. Well, thank you both so much for your time. Um, and yeah, for the time, for all the knowledge that you've shared. And thank you all for attending as well.
Mhm. Thanks for joining.
Thank you all.
All right. And I'm going to go ahead and end this talk. Thank you.
Thanks.